making the time. I really appreciate you.
Great, you're live.
Okay, so we are live. Wonderful. So good afternoon and welcome to the first interim briefing for the House Health and Government Operations Committee. This is a virtual committee briefing, so I ask for your patience. If we encounter any technical or streaming issues, they will happen. And if something happens with mine, Vice Chair Collison will take over, or someone else, okay? With my connection. This briefing is being streamed on the Maryland General Assembly YouTube channel, so we are there watching us. Members will be muted throughout this briefing. If you have a question after the presentation, please use the raise function, which is located either underneath the participants list on the right side of your screen or under the reactions bar at the bottom of your screen. After I call your name, please unmute yourself. Remember that even though we're meeting on Zoom, please refer to our usual committee rules of one question and one answer from the panel, not one question and one answer from each individual panelist. And I am going to be flexible, and I will try my best. Please keep your questions brief. Today's briefing will begin by meeting the new acting insurance commissioner, which I know you guys don't know her, Marie Grant, followed by a presentation from the Maryland Insurance Administration on the approved 2025 ACA premium rates, followed by a question and answer session. The briefings will conclude with an update for the Maryland Health Benefit Exchange on the reinsurance program and the Young Adult Health Insurance Subsidies Program, which our committee has been a leader on, and I'm grateful for your leadership. And it will follow by a question and answer session. We will begin with Acting Insurance Commissioner Grant from the Maryland Insurance Administration. And I will mute myself. Acting Commissioner, please go ahead. And welcome. And we're so happy to see you in this role.
Oh, thank you so much, Madam Chair.
You're
Good
welcome.
afternoon, Vice Chair Collison, committee members, Marie Grant, as the chair noted. I started October 1, so I'm in week 2 of being acting insurance commissioner at the Maryland Insurance Administration. I'm really honored to take on this role, and I look forward to working with you on all the various health insurance and health coverage issues that you all work so closely on. I think, as you all know, but I just want to reiterate, and that I've just seen right from walking in the door and even before, that we have an amazing team here at the Maryland Insurance Administration. And I'm joined by members of that team on the call today. You'll hear in more depth from our Chief Actuary, Brad Bobin, on the rate review process for 2025 that all happened before I arrived and was very well done and thought out. Just a quick note on some of the health issues that I personally care deeply about. First of all, rising healthcare costs.
Acting Commissioner, hold on one second. Just for the record, so that it's reported, if it is properly, Delegate Lopez is on Amtrak, and she's actually very committed. And on Amtrak listening, Delegate Bagnall is a passenger as well, okay? And they're very committed and didn't want to miss this, and thank you for your commitment. Go ahead.
Great, thank you so much, Madam Chair. So rising healthcare costs, healthcare access, and mental health parity and network adequacy, which I know this committee did a tremendous amount of work on last session, and that we would be happy to brief you on our progress at any point that's appropriate. So with that, I'm happy to turn it back to you, Madam Chair, if we wanted to dive into the next presentation.
No, we'll go to the next presentation if that's okay with you.
Yep, that sounds great.
Okay, so we have Brad.
Great. And Madam Chair, I think I'm going to we have a slide deck here. I think I'm going to kick us off and
Go
then
ahead.
turn over the bulk
Absolutely.
to Brad.
We'll follow your lead. Thank you.
Okay, great. So for the committee's refresher, I just wanted to, and we can move to the next slide. Brad's going to be talking about specifically individual and small group Affordable Care Act, or ACA, rates and approvals for 2025. But I wanted to just quickly remind folks of the different health insurance, major medical markets that we regulate and some of the difference between the regulation of each of them. So for individual ACA plans, some of the key features of these plans are they're guaranteed issue and renewable. There's no pre-existing exclusions. Preventive care is covered at 100% at no cost or co-pays for covered folks. Children are covered up till age 26. There's no lifetime or annual maximums. These plans have to cover all essential health benefits and fit into an actuarial value. That is, they need to be bronze, silver, gold, and meet certain financial requirements to fit into each of those categories. There's a maximum out-of-pocket set by CMS, and that's $9,200 for 2025. And there's only a few rating factors that can be used to make differences in rates in individual ACA plans. So that's age, it's family composition, essentially how many folks are in your family and on the plan. Geographic region, there's different geographic region ratings across the state, and then tobacco use status. And then rates change once per year on January 1, and all plans run from January 1 through December 31. Next slide, please. Small group Affordable Care Act coverage. So these are plans that provide coverage for employers with 2 to 50 full-time equivalent employees, guaranteed issue or renewable, like individual, no pre-existing exclusions, preventive benefits covered at 100%. You'll see a lot of the same things here, right? So kids covered till age 26, no lifetime or annual maximums. Plans must cover all essential health benefits and fit into a given actuarial value, and subject to a maximum out-of-pocket expense. And similarly, there's limited rating factors, modified community rating in the small group. In the small group, a difference is that rates can change quarterly, and then plan years can start at any month. So they don't necessarily have to begin on January 1st for small group plans. Next slide. And then there's large group, which we're not talking about today, but which we do regulate. This is for employers with more than 50 full-time employees. There are some key protections from the Affordable Care Act in this large group fully insured market. No pre-existing exclusions, preventive care, again, no cost sharing, children covered until age 26. These plans have to meet a minimum value of 60%, and they do not need to cover all essential health benefits. But if they are fully insured, they do need to meet Maryland's mandated health benefits. There's also a maximum out-of-pocket. And in this market, there are a much wider variety of rating factors that are permitted. And so insurers can rate on age, gender, industry, geographic area, and health status can be asked about during group underwriting. And then plans generally are rated on experience. Next slide. And then lastly, we do still have some grandfathered plans. These are plans that were sold before March 24th, 2010. And as long as they don't change any of their key benefit designs, there are folks that are still enrolled in those plans. And so now I'm happy to turn it over to our Chief Actuary, Brad Bowman, to give an overview of the rate review process and talk about this year's work.
Wonderful. Thank you so much for your presentation. Next, please.
Thank you, Madam Chair, for having me here today. So just as a general part of our rate review process, Maryland Insurance article requires that rates must not be excessive, inadequate, or unfairly discriminatory, and that they must be reasonable in relationship to benefits. Otherwise, the commissioner shall disapprove or modify the proposed rate filing. So we began this filing cycle by reviewing the 2023 experience period claims. So calendar 2023 was the starting point, and we looked at those claims to compare to what the carriers had previously projected and what they were expecting for 2023. Then after we got the experience period claims, we also looked at the assumptions that went from the experience period to the projection period. So we reviewed the assumptions both in aggregate and individually to make sure that they were reasonable. Some of the key assumptions included claims trend, both cost and utilization, morbidity, which is the relative health status of the pool, operating expenses, profit margin / contribution to reserve, risk adjustment transfers, in the individual market, reinsurance recoveries from the 1332 waiver, and in the individual market, the impact of the Medicaid unwinding on the enrollment and the morbidity of the pool. As you know, the Medicaid had been frozen for COVID from disenrollments, but over the last year, between April of 2023 and March of 2024, the disenrollments resumed, and there was a large rise in enrollment in the individual market. And we'll get to how large that rise is in the coming slides. So all of our rate filings were submitted on 5/20, but back in May 20th, and we approved them on September 5th. We had a public hearing on 7/9, and we were also accepting public comments from May 20th through August 9th. So there was public opportunity throughout the process to participate. Next slide, please. So overall, what the carriers asked for was an average of 6.7% when they came in May, and the final approval was a 6.2%. A big new development in the market is that WellPoint has entered the market in 2025 with 10 new plans that are going to be offered statewide. So with the entry of WellPoint this year and the entry of Aetna last year and United 4 years ago, now we're going to have every county is going to have at least 4 carriers to choose from. And that's up from before the reinsurance program when there was only 2 carriers to choose from. In most counties, and some counties only had 1 carrier. The reinsurance attachment point was increased from $20,000 in 2024 to $21,000 in 2025. That's according to the waiver extension plan. And that's different than the first waiver. The first waiver, we kept it steady at $20,000. So all things being equal, that put about 0.6% of upward pressure on rates, versus just leaving the attachment point unchanged. But that was planned as part of the plan to balance the budget and make sure that the program is solvent by raising the attachment point in line with claims trend, so that there is not excessive rise in reinsurance costs. But despite this upward pressure, the 6.2% trend rate increase is coming right in line with the trend for the market, which is 6.1%. The 6.1% trend can be broken down into 3 major components. Of a 4.3% hospital trend, that's in line with the HSCRC update factor, an 8.5% professional trend, and a 10.5% drug trend. And then finally, premiums remain 17% lower than they were in 2018, thanks to the continued success of the reinsurance program. So, even though there's been, 7 years now of rate inflation, we still have premiums 17% lower than they were before the reinsurance program began. Next slide, please. So this shows details by carrier of what was approved for the individual market in 2025. The second to last column is the approval column. The yellow number there is 6.2% overall. But you can see that ranges from a 5.1% for CareFirst HMO legal entity, up to an 8.8% for Optimum Choice, that's or for Aetna Health. And so you can also see what they asked for originally. The original ask ranged from 4.7% up to 14.2%. So
Hold on a minute. Delegate Warman, could you be so kind and mute yourself?
Sorry about that.
Oh, it's okay. It happens. Don't worry. It happens to all of us. Go ahead.
Thank you. So you can see that, double-digit increases were asked for by CareFirst PPO and by Aetna Health, and those both came down significantly. So, the range of approved increases is narrower than was asked for. And then that last column shows, compared to what it was in 2018. So that's where the minus 17% comes from. And then the other thing to point out is the enrollment. The enrollment here is up to 271,000. That's up about 18% from last year. And that's due in a large part to the Medicaid unwinding, combined with the ARPA subsidies, and the reinsurance program. So the Medicaid unwinding is removing people from the Medicaid rolls, and the ARPA subsidies and the reinsurance program are giving them affordable premiums when they come off of Medicaid and are sent over to the exchange. Next slide, please. So this is a breakdown of the details of trend that we saw this year in the individual market. This is an average between all carriers. And so this shows it broken down by all the service categories that they're required to break down in their actuarial memorandum: inpatient, outpatient, hospital, professional, other medical, which is things like ambulance or home health care or DME, or dental or vision, things that don't fit into one of these other major categories, capitations, and then prescription drugs. The major categories, like I said, are hospital, which we combined a total hospital down at the bottom, and that's where that 4.3% comes from. Carriers have a lower inpatient trend, a 3.8% inpatient hospital trend, and a 4.8% outpatient hospital trend. But then you can see the prescription drug at the last row has the highest trend. It's about 50-50 cost and utilization. The unit cost is up 5.5% year over year, and the utilization trend is up 4.5%, and that's a 10.3% compounded. And one of the factors driving this from SOA studies and from NIC studies that we've seen is that GLP-1 agonist, the Wegovy, the Trulicities are a big driver of drug costs across the country. We're going to look into this more next year, as well as try to track gene and cell therapy and biologic drugs, all of which are expensive specialty drugs. But we do know that the prescription drug driver is the specialty drug driver. But we're trying to get to what specialty drugs are driving that. Next slide, please. So on the individual ACA dental, we originally had an average rate increase request of 2.5%. And what we actually approved is an average increase of plus 0.3%. 55% of dental policyholders are going to be getting rate decreases. One carrier, Delta Dental, requested a large 18% increase, but what actually got approved is a little over half of that at 9.7%. And claims trends in dental remain very low compared to medical in the 2 to 3% range. Next slide, please. So this shows what was approved by carrier in that last column. You can see that the CareFirst legal entities both gave a 5% decrease. And that, originally there was a 2.54% request, but that fell to 0.3% when we brought down that Delta Dental request. Next slide, please. All right, so in the small group market, the carriers originally requested 6.1% when they filed in May. And what we approved in September was a 4.5% increase. So a drop of 1.6%. There was significant variation by carriers, but they were all filing for increases, and the increases ended up between 1.5% and 18.8%. The major driver of the rate increase in the small group market is trend. The average small group trend is 7.1%, and the 11% prescription drug trend is the main driver of that. Even though they had a 7.1% trend, they're getting a 4.5% average rate increase, and that's mainly because of 2023 experience being favorable. Like I said, the 2023 experience is the starting point of it all. Several carriers had already filed for rate decreases in 2023. They can file for mid-year rate changes, and that had happened for 2 carriers. And so in general, the 2023 experience came in better than expected. And then even though small group trends are higher than individual, small group claims remain significantly lower. So for 2023, the small group average claims level was $522 per member per month versus the individual of $654. So just wanted to keep that out there. Next slide, please. This is the small group market by carrier. This shows what they filed originally in May versus what they approved. The far right column is what got approved in September. And you can see that it ranges from a low of 1.5 to a high of 18.8. But in general, most carriers were coming in the low to mid single digits. And there's also a pattern by quarter. You can see that first quarter and second quarter are lower increases than third quarter and fourth quarter. And that's because of those mid-year rate changes. Basically, people in third quarter and fourth quarter have already gotten a rate decrease that went through last year. And it hasn't gone through for the first quarter and second quarter yet. So that's why these rates increases are lower. All right, next slide, please. Another thing we wanted to mention was about the advanced premium tax credits that were enhanced under the American Rescue Plan Act in 2021. These were extended till the end of 2025. So right now, all of the rates that we just went through reflect the fact that these ARPA subsidies will be in effect. These subsidies did 2 things. They greatly increased the subsidy amount for those already eligible for subsidies. On average, it increased by about 40% extra subsidy. And then it also increased the number of people eligible for subsidies by removing the 400% cliff and allowing subsidies at any income that the benchmark plan would be more than 8.5% of your income. And so this expanded it to a lot of mainly older and older couples, older families, over the 400% mark who are now eligible for subsidies. Since May 2021, when the subsidies were first enhanced, we've seen a 37% increase in the number of subsidized individuals from 126,000 to 172,000. That's 46,000 gain. This is from the MHBE's monthly data report. And if these subsidies are allowed to expire, there is a big fear that we're going to lose a significant amount of this enrollment. And this enrollment in general has been healthier and younger than the pool in general, and has been helping to push down morbidity. If we lose this enrollment, there is a potential for significant double-digit increases in 2026. If you could go to the next slide, please. So this compares the premium under subsidy and under the original ACA. For a sample member, this is an age 64-year-old. I chose age 64 to show the example of the premium cliff. And so under ARPA, this individual, the how much they would pay would vary in their income, and the higher the income, the higher the premium. But that there would be no limit to where they could get subsidy. And so it would always stay below 8.5% of their income. But under the original HCA, it's a lot higher percent. And so you can see the second column, the jumps are very high. On a percentage basis, you've got people at lower incomes seeing their premiums more than double, 200% increase. On a dollar basis, you're seeing people with more than $100 increase per member per month. And that's from bringing it back to the old original ACA level. This is, the potential premium impact if ARPA expires as scheduled. And so this is federal action that needs to take place, for ARPA to be extended. But it's really important federal action. So, we want everybody to know about the importance of this and to encourage action by our federal representatives. Next slide, please. It's just in summary, key takeaways. Marie, were you going to take this slide?
No, take it away, Brad.
Sorry.
No, you're okay.
So competition continues to improve the individual market, with WellPoint entering for 2025 after Aetna entered in 2024. The continuance of the enhanced federal APT subsidies are key for stability in an individual market. The MIA is monitoring the increase in drug trend and will attempt to identify the drivers of this drug trend. And the MIA is also monitoring the decline in small group enrollment, something I didn't call out on my slides, but something that we've observed over time. So with that, I think I'll turn it over to questions.
Okay, thank you so much, Brad and Acting Commissioner, for your presentation. I'm going to open it up now for our members to ask questions. And I see the first one from Delegate Hill. If you will be so kind and unmute yourself, please, if you're able to put your video on, it is highly encouraged. Thank you so much. Delegate Hill is going
Thank
to
you,
be
Madam Chair.
followed by Vice Chair Collison and then Delegate Taveras.
All right, thank you, Acting
Welcome.
Commissioner, Administrator, and Brad, and Madam Chair. My one best question, the slide number 14, Brad, you talked about 37% increase because of the ARPA subsidy increase. I'm not clear, these folks who are now being subsidized, are these folks who would have had no insurance before, so they're newly insured? Are there folks who can now afford better insurance because of the subsidy? Or are there folks who are pretty much at the same plan level, but now it's less out of their pocket?
I mean, I think it's a mix of both. I mean, we've seen a gain in 37% of enrollment, and we've seen a gain in both total enrollment and in subsidized enrollment. So it's not just a shift from people not being subsidized to being subsidized. So there is an increase in overall enrollment. Like I said, a lot of it is recently coming from the Medicaid disenrollment. These are people that had, that would have been eligible for a subsidy plan based on their income, but were frozen on Medicaid for the 3-year period where CMS wasn't allowing anybody to be removed because of COVID. So I believe a significant portion are those as well. But it is an increase in 37% in the number that is getting subsidies. Yeah.
Thank you.
You're welcome. I want to first welcome Delegate Teresa Werman. It is her first hearing in HGL, and she is our new colleague, so we want to welcome her. We're going to go next to Vice Chair Collison.
Thank you, Madam Chair.
You're welcome.
And welcome, Acting Director Grants. Good to see you in that seat. Good to continue seeing you on our screens. And thank you, Brad, for your presentation. I heard you say you're going to dig deeper into the prescription drug issues. I mean, it's a very stark finding, piece of data to show the difference in trends between medical services and the drugs. So, you know, I'm concerned about that. And I understand that, you know, the studies are initially showing us that it's those GLP-1s, I think they're called. So the question, I guess, in your investigation, because I wouldn't think we'd have this information quite yet, is are pharmaceutical companies, are the cost of those drugs going up significantly because of the demand? Because these drugs were developed for one thing, but they can now be used by something else and are being used by something else. So we've increased the utilization, I suspect, really dramatically. So that my question is, have the prices that we're paying for those drugs risen disproportionately to the utilization? Again, it might be a part of your study.
Yeah, I would say we still need to get Maryland data to confirm that this is true in Maryland, but nationwide it is a unit cost issue as well as a utilization issue. That yes, the cost of the units are going up much faster than inflation, much faster than the general rate of drug trends. And so, you know, that is something that we're going to look at as well. We're going to look at both the utilization and the cost separately to tease apart those two parts and see how they've been changing over time.
Thank you very much for that. I appreciate it. And I look forward to hearing what you find out.
Thank you. Delegate Taveras.
No, thank you, Madam Chair, and I want to thank you for this presentation. I just had just a definitions question on what the meaning of SOA and GLP-1 are, and you're looking at the impact of Medicaid on enrollment, which obviously has increased, or the loss of Medicaid on enrollment. That's a positive, but overall, is it that we're enrolling more youth in that because it seems like it's the numbers that I saw was like it was more youth driven increases. So that's overall decreasing morbidity rates overall. Am I understanding that right? I mean, you didn't dig in deep into those actuarial outcomes.
As far as what the abbreviations stand for, SOA stands for Society of Actuaries. I don't know off the top of my head what GLP-1 stands for, but those are the class of drugs like Wegovy and Ozempic that are used for both diabetes and for weight loss. That are growing in popularity and that a lot of people are trying to get prescriptions for. As far as the relative morbidity of the new entrants, in general, the carriers assumed a slight improvement in morbidity based on the Medicaid enrollees. I think the average was 1% healthier than the existing enrollees. But yes, there is a surge in young adults, but there's also a surge across all ages. So it's not a matter of just young adults coming into the market. It's also new older members, and so that's kind of shifting things on the other side as well.
Oh, interesting. Okay, thank you.
So according to Dr. Google, GLP-1 drugs are known as glucagon-like peptide-1 receptor agonists. They're the drugs that are help regulate insulin and blood glucose levels. That's what Dr. Google says. Delegate Riley. Delegate Riley.
Thank you, Madam Chair, and thank
You're
you for this
welcome.
presentation from the Acting Secretary and her team, Brad. So anyway, I received a constituent email in September, which I did forward to MHBE and also MIA for a response. So I'm sure you're working on that. I appreciate that. But it's possible, and looking at these charts, it looks like Aetna is still within the small group because the email that the constituent said that he was concerned because Aetna was dropping out of the small group. So you don't have to get into the details, but you can just let me know, are they in or are they out? And then we can, do that offline with his response.
Aetna is exiting as of the second quarter of the year. So I didn't get into that. I probably should have. So they're shown on my chart because they are for sale through March 30th. But as of April 1st, they're not going to be available anymore for either renewals or new business. And so I don't know if David or if there's anything else to say on that, but yeah, they all have exited the small group market
So
officially.
then, okay. I obviously this person, I guess, works within the industry, and he was very upset that Aetna had to pull out, and he's, stated that there was some kind of conflict, and that either the Maryland Health Benefits Exchange or MIA did not give them enough time or ask for additional information. So I look forward to, response from both of you so that I can, respond to my constituent. But yeah, it's always sad, I guess, to lose a insurance company that wants to be within, our exchange. So I look forward to the response. Thank you.
You're welcome. Acting Secretary Grant.
Thanks, Madam Chair.
You're
I just
welcome.
wanted to follow up on that a little bit, and we'll definitely get Delegate Riley a response to you. Aetna has filed with the MIA for a withdrawal for Q2 of 2025, as Brad noted. My understanding is that this is not a Maryland unique situation. So again, we'll make sure to dig into what we can share with you more about the reasons for their withdrawal. But my understanding is that this is not just Maryland. This is something that they have been looking at in other states. And then also just want to add, Brad talked about, but the small group market again is something we're going to be keeping a really close eye on. We're seeing declining enrollment. We're seeing a carrier pull out, which regardless of the reason is not something we want to see. And so we'll definitely be keeping in close contact with you on that. But yes, follow up specifically soon and more to come for sure.
Will you be so
Thank
kind
you.
and send the information to the entire committee? Is that okay, Delegate Riley? Delegate Riley?
Yes, Madam Chair, that would be great.
Okay, thank you so much. I
Thank
do
you.
not, thank you for the question. I do not see any other questions, but I do have one. And it's one that I've been thinking for a while now. In reviewing the rate increases, any considerations for payment rates to providers, given that Maryland ranks third from the bottom, as well as insurers spending money purchasing other business, right? Like the insurers are basically buying new business lines, and these providers are not getting reimbursed, properly, right? They're low compared to other states. Any considerations to that?
Yeah, I can
Commissioner.
hop in a little bit, Madam
Yes.
Chair, and then Brad back me up with anything I'm missing on the actuarial side. So I think overall, when Brad and the team look at rates for the individual market, they're really looking at it mostly within the vacuum of that individual market and the risk and experience within that market. So that wouldn't necessarily be the place where we would examine ensure investments that would happen within another area of where we would take a look at some of those things, except to this extent that they're showing up in their administrative costs. And just again, within the market themselves, carriers do have to meet a minimum medical loss ratio. That is, they have to pay a certain amount of their costs towards claims. And if they don't meet that medical loss ratio requirement, they have to send rebates back to members. Within the individual market this year, I think that we did see actually a growth in professional fees and trends. So that was higher than the average trend. Our hospitals, and again, this is Brad's going to clean me up, but we saw hospitals track at about their update factor with the HSCRC. And then we saw overall professional trend, which is most of our doctors' fees, at about 8.5%. So we did see a jump, I think, in unit cost and utilization there.
And do we know is there someone tracking these carriers when they're buying new business lines? Are we keeping a close eye on this?
That's something we can get back to you, Madam Chair. We have different sort of scopes of authority over our carriers, depending whether they're nonprofit, whether they're headquartered in Maryland, and then like whether they are national. But we can get back to you with more detail on that.
Thank you. I appreciate it. And if you could send it to the whole committee, that would be great.
Yeah.
Thank you. Delegate Hill.
Thank you for allowing me to ask Delegate Bagnall's question. So along those lines, Brad, can you explain when companies come in and they request an increase of 9%, 18%, we look at the assumptions and we're interested in keeping rates low, and we make some decisions about those are valid requests or not, and then we hold them to a lower number. Do those companies, two things, do they come back the next year and keep asking to get there again? And if they don't, if we don't give them what they're asking for, and we've judged that what they're asking for is excessive, how do they make up for that gap between what they say they need and what we actually allow them to get? How do they do that?
I mean, no, they can't come back the next year and make up for past losses. There is no making up for a gap. If they turn out right and rates should have been higher, then they lose money if we push down rates inappropriately. But we take an objective approach, and there is uncertainty to all of these rates, and there is a probability that it's going to come out higher or lower. But most years it comes in pretty close for most carriers. There's the MLR rebate mechanism, so that if carriers make too much money, that they reimburse it to the consumer, but it's asymmetrical, so there's nothing to make the carriers whole if they lose money. But ultimately at the end of the day, carriers have generally been making their profit margins in this market since the reinsurance program was put in place. There were some large losses in this market from 2014 to 2018, but with the reinsurance program in place as a backstop, stabilizing things, carriers in general have been making their profit margin, and I think that's why more carriers want to enter the market, because they see that existing carriers are able to operate at a stable, steady margin.
Thank you. And I know Delegate Bagnall is going to ask her real question now. Go ahead, Delegate Bagnall.
Thank you, Madam Chair, for the second bite at the apple. So this is actually, I think, a follow-on to your question and to Delegate Hills, but specifically as it relates to dental, given that dental is an add-on as opposed to mental health, which is required. There's required parity within the law. When you speak to increases within dental coverage, is that going to create a greater disparity between the reimbursement rates for private insurance dental and the reimbursement rates for Medicaid, which are still, significantly low?
We don't deal with the reimbursement rates for Medicaid in our office. So I can tell you, the reimbursement rates for dental is pretty steady. That's what drives that low claims trend is a low increase in reimbursement rates. But I can't speak to how it compares to the MCO. That's not part of our review.
Okay, thank you.
All right, I don't see any other questions. I want to thank the acting commissioner and I want to thank Brad for being patient as we ask these questions. For the members, if there are any questions that when it's done, you think, oh, you should have asked, like I do sometimes, just feel free to email them and then make sure that we all get the answer, which is great. Thank you so much. It is great to see you again in that role, and I'm sure we'll see you again many times, okay?
Absolutely. Thank you all.
You're welcome. And now we're going to go to the second part of the agenda. Delegate Woods, I want to make sure you're in the Dominican Republic, right? Okay. Just kidding. So we have an
Oh,
update.
how I wish. Oh,
I
how
know,
I
right?
wish.
You and I both. We have an update on the reinsurance program and the Young Adult Health Insurance Subsidy Program. As you know, the reinsurance program has worked really well in Maryland, really beautifully. That is because we have an amazing person that has been a key partner to our committee, helping us, execute it. And that is Michelle Everly, who's the Executive Director of the Maryland Health Benefit Exchange. Michelle, it is always a blessing to see you, and I want to thank you on behalf of the committee for all the great work you do. So you can go ahead and take it away.
Very good. And I do know we have some slides, so we could put those up. That would be great.
Absolutely.
Thank you, Chair
You're
Penniman.
welcome.
And thank you, committee, for having us here to give you an update today. If we can go to the next slide, please. I have with me today Johanna Fabian Marks, our policy director, and we're going to talk about actually three things. I'm going to sneak in a little bit on impact because it relates to our reinsurance program and our young adult subsidy program, and some of the highlights from this year, and then some of the goals as we move into open enrollment in 3 weeks. So I'll be brief on all of these, but they really are important and relate to the deeper dive into the reinsurance program and young adult subsidies program that Johanna will then take over. Next slide, please. Next slide. Okay, so as you all know, we are Maryland's state designated marketplace established in 2011. And since then, we've been working really, really hard to fulfill our mission of high quality, affordable health coverage for all Marylanders. In 2019, with your support, we instituted the state reinsurance program that led to a 30% reduction in premiums, and it continues to afford Marylanders the lowest bronze and gold health plans in the nation. After the institution of the reinsurance program, we saw an average increase of 3% in enrollments over a 3-year period. That was just based on that initial reinsurance program. Then in 2021, through the American Rescue Plan Act, the expanded tax credits came into play. And we saw that since the introduction of that, we've seen an average 11% increase in enrollments over a 3-year period of time. And we can't state, Brad alluded to the importance of those expanded tax credits and how important they are, and especially folks over 400% or higher income earners, and the impact that they've had in our state into our reinsurance program. We have been working with other, the NAAC and other national organizations to really advocate and provide information to our federal delegation and the entire Congress on how important it is that Congress acts sooner rather than later on this. And after today, I will send to the committee, we developed some fact sheets for our federal delegation based on their congressional district of the impact. So while it's not at your district level, it's at the federal level, it will be very helpful. And we could, of course, make some more of those if we wanted them at state level. So anyhow, continuing on from that, then after 2021, we had the ending of the public health emergency. And since then, we've seen a 17% increase in enrollment. So just really tremendous growth since we began in the beginning of 2014. Now, the outcome, we talk an awful lot about, well, what, all right, we have the ACA, we have all these enrollments, but what's the impact really been? The outcome of these enrollments are evident in so many ways. And for instance, I have up here, and there's a video you can click on, Shelley Eldridge, who's the founder of Visions Creatives, and she credits her ability to start a new business because of the affordable health coverage she found through Maryland Health Connection. I had the benefit of seeing Senator Cardin at a community forum a couple weeks ago, and he was talking about the double-digit small business startups in Maryland, particularly for women-owned businesses. And I was so happy that I could share with him and with the group there Shelley's story and the impact of what the work we've done in our state and the work that the federal government has done to really help bolster this. But here's a really good indication of growth in small business, but not all those small businesses are more than one person, so they may be in the individual market. Another outcome, and this one is my favorite one, it just came out this year on June 1st, but finally, we're always saying, well, let's see what the medical benefits are. And on June 1st, the American Surgeon released a study that was conducted by Howard University School of Medicine and the University of Alabama, comparing, and this is Maryland-specific data, they compared Maryland's amputation and revascularization rates at two segments in time, pre-ACA and post-ACA. What they found was broadening the wellness benefits and all the coverage that we have for preventive conditions. Amputation rates dropped by from 56% to 23% after ACA implementation, while revascularization rates soared from 44 to 77%. They concluded in their study that the broader insurance coverage enabled more people to obtain basic routine care, which in turn led to better preventive care for people with diabetes. Now, this study, why I'm so excited about it, is that we've watched through the state reinsurance program, we always have the highest conditions that we pay out reinsurance funds to. And consistently, diabetes is one of the highest conditions. What we've started to see over the last 3 years is that trend go down. And so we knew that the trend was going down, but we didn't have a study behind it to demonstrate that. And I have to also suggest that the focus work by Maryland Department of Health on diabetes, on controlling diabetes, and on at the exchange, what we've done a lot of benefit design about coverage for diabetic conditions, zero, pre-deductible, no copays. And those focus efforts, I think, have also helped. But now we have a published study that supports that. Next slide, please. So 2024 highlights what we've seen. Premiums among the lowest nationally. Again, our gold, our bronze and gold plans are just the lowest in the nation. After, we talked about all of the impact and the growth in enrollment, but I want to just get here and not miss that. So our average premium is the 5th lowest in the country at $475. And again, after tax credits, that drops it down to $112 a month. So we really have seen where, and again, this is the reinsurance program that has made health coverage very, very affordable in Maryland. The value plans are our Maryland standard plans. So it's the same benefits from carrier to carrier. The only thing that's different is the network and the cost. so people can compare apples to apples. And what we look at every year, and we typically always have work groups that come in and look at where are the areas we want to design our value plans to have the most benefit to Marylanders. And this is where we've done a lot of work around diabetes. The next area that we're looking at, we've just started this with our Standing Advisory Committee and with our work groups, is to look at maternal health and infant mortality. We know from reinsurance, it's another high cost driver. We'll be working very closely again with the Department of Health and the work that they've been doing to try and make our plans meaningful, again, for that condition as well. Young adult enrollment, another program that with your support, we've been able, and Delegate Kerr's support, who led that effort to get the young adult subsidy program in place. Again, this has just been hugely successful. And in fact, more than 57,000 of that over 200,000 individuals we have enrolled are in that age 18 to 34 range, which we know is typically a healthier range for the risk pool. The record enrollment, can't say enough about the collaboration between the Department of Health and all of our stakeholders on the Medicaid unwind, the public health emergency unwind. We are lockstep with them in terms of communications, in terms of auto enrollment into commercial plans. As of July 31st, we are able to transition nearly 35,000 enrollees from Medicaid directly into a commercial plan. And again, from someone having paid zero for a health plan, now having the option of having a health plan that is $0 or very low cost, allowed that transition to occur very smoothly. So we've seen a 14% increase in our total enrollments year over year. I talked about equity advances in terms of diabetes and how we look at that and how it affects our different communities, our Black community specifically. All of our outreach efforts have been really focused on our Black and Hispanic communities, and that's allowed us to see double-digit growth in both areas, which we will not let our foot off the gas pedal on that. That continues to be a priority. And finally, the new enrollees. Our new enrollees, these are not people that renew year after year. These are just new, are up 35% this year. Again, that is three things that we know. The expanded tax credits, it has made the premiums affordable, the end of the public health emergency unwinding, and then thirdly, the young adult subsidy, which really has allowed growth. Next slide, please. So as we enter into open enrollment, which is 3 weeks away, and please let all your constituents know this is the time. Shopping is available right now. We are going to build on the successes of 2024. We're going to continue to focus on our young adults. We're going to continue to focus on our uninsured populations. We'll strengthen our outreach to our metadatas. We do analysis down to what we call the PUMA area. PUMA is a grouping of 100,000 people, so it's a very small, and we can look at across the state based on those PUMA data where our uninsured populations are, and that's where we target our outreach efforts, our boots on the ground, our money to work with stakeholders in those areas. DACA residents, I didn't talk about this, but beginning November 1st, the law goes into effect, and the deferred action, I should know this by heart, DACA residents, deferred action for childhood arrivals, can get a health plan with financial help with a coverage date effective of December 1st. So this is something new we're thrilled about. This is a prelude to us ultimately being able to offer health coverage to all Marylanders, regardless of documentation status. So we're really excited about that. We'll continue to promote value plans and making sure that they're meaningful for what our state needs them to be. And then continue to promote our other offerings as well. Dental, and we added vision in last year. This will be our second year going in with vision plans. And I didn't talk about our small business health plans, but we are instituting a new portal next year for small business, again, trying to really meet the needs of small businesses to get their employees enrolled. I will stop there, and that gives you a brief run through before Johanna takes us into the reinsurance program deep dive. So thank you very much.
Thank you. And we'll take questions at the end if that's okay. So let's go on with Johanna. Johanna, you can go ahead and get started.
All right, great. And thank you for the opportunity to give you an
Welcome.
update today on the reinsurance program and the Young Adult Subsidy Program, which, as you know, are two of our state's major programs to make health insurance more affordable in the individual market. And of course, this committee was instrumental in the creation of both of these programs. So I'll start off with reinsurance and with a quick recap of the history behind the program, which is much of this will be familiar to many of you, but just wanted to run through it quickly for any of the newer members who could benefit from the recap. So as you know, in the early years after the Affordable Care Act passed, we saw significant double-digit premium increases, and that's a problem because it leads healthy people to drop out of the market, and that pushes premiums up even more. And you can potentially, veer into the dreaded death spiral in health insurance lingo. So the state saw these climbing premiums and took action to implement the reinsurance program in 2019, which led to 3 years of premium decreases. And then at that point, the full impact of the program had been incorporated into rates. And since that point, as we would expect, we've seen moderate premium increases at or below medical trend, which Brad also spoke to. And as he mentioned, even with several years of increases, rates are still more than 17% below where they were in 2018, which is pretty amazing when you think of inflation and how much more everything else costs compared to what it cost in 2018. So really a testament to the program. Next slide. And again, a quick refresher on how reinsurance works. Of course, through reinsurance, we reimburse insurers for a portion of their claims costs, and lower claims means that insurers can charge lower premiums. The exchange's board sets the payment parameters for the reinsurance program every year. Since its inception, the design of the program has been pretty steady. In 2024, the program is covering 80% of claims costs between $20,000 and $250,000 for an individual. So that means if I'm enrolled in the individual market and I incur more than $20,000 in claims in the year, the reinsurance program will cover 80% of those costs up to $250,000. If my costs exceed $250,000 in the year, the insurer is then again on the hook for 100% of the cost over that amount. Next slide. So this slide gives you a sense of how those payment parameters translate into dollar figures and into impact on the market. So on the left-hand side of the slide in the pie chart, you can see that in 2023, about 7% of enrollees in the individual market, which is the blue wedge, qualified for reinsurance. That means they met the threshold of having at least $20,000 in claims costs in the year. So just 7% of the market met that threshold, which is pretty consistent with what we've seen since the start of the program. Then when we switch over to looking at the right-hand side of the slide, we see claims. So in 2023, total claims in the market for everyone totaled about $1.6 billion. Reinsurance covered nearly $570 million of those costs, so about a third of costs in the individual market. Again, that's been a pretty consistent ratio since the program started and is about what the program was designed to do. So when we look at that pie chart on the right-hand side, you can see, again, that reinsurance covered a third of costs in the market. That's the gray wedge. An additional third of costs in the market, the orange wedge on the right side, is attributable to that same 7% of individuals who qualified for reinsurance, but that portion of costs, that third of costs, was not covered by the program. That's covered by insurers. It's either below that $20,000 level or above that $250,000 level, or it's that 20% portion that insurers are on the hook for in between those two amounts. The last third of costs, the blue wedge, approximately a third, comes from the 93% of enrollees who didn't meet the threshold for reinsurance payment. So again, consistent with prior years, we see that a small number of individuals is driving about 2/3 of costs in the market, and reinsurance is covering about half their costs. So you can kind of a testament to the impact and size of the program. Next slide. So what are we getting for this investment? As you've heard, really major results. We continue to have some of the lowest individual market premiums in the nation. We're about 25 to 30% below national averages for health insurance plans in the individual market. So pretty consistent since the program started, and is really just a major improvement in affordability, particularly for those who are not eligible for federal subsidies and are paying the full cost of their plans. Next slide. So those lower premiums, in addition to other affordability programs that you've heard, like the increase in federal subsidies, has really helped to drive enrollment increases since the program launched. So you can see in the graph here that we saw enrollment decline in the years before 2019, but then start to climb steadily once the reinsurance program began in 2019. And remarkably, overall individual market enrollment is up more than 40% since the reinsurance program started. Next slide. So here I have just a couple slides on the financial situation of the program. The first, and we have these divided into two scenarios. The first scenario, what you see here, assumes that the enhanced federal subsidies originally passed under the American Rescue Plan Act will end at the end of 2025. So that's what's in current law. We're hoping, as Brad mentioned, that Congress will take action to extend those, but if they don't, that extra federal funding for subsidies is going to end at the end of next year. That has an impact on the reinsurance program. It will reduce the amount of federal funding that we get to support the reinsurance program. So I'll just, I've shared this graph over the years with this committee before, but we'll just do a quick reorientation to what you're looking at here. So we've got each year of the program starting in 2019 and projected out through 2028. And we've got a bar for each year. The green portion of the bar is the amount of federal funding coming in, and the blue portion of the bar is the state funding that we derive from the 1% assessment that supports the reinsurance fund. So that's how much funding the state gains each year to support the program. In the red line that goes across the top, that's how much the program costs each year, has cost, how much we project it will cost. And the purple line shows our state reinsurance fund balance. So how much we have kind of in reserve that rolls over to future years to help support the program. So in the more or less up to this year, that red line has been below the bar, meaning the cost of the program has been somewhat below the amount of revenue that we're bringing in on the state and federal sides to support it. That means our fund balance has generally grown modestly, with a dip in 2022 when we did have to draw down on that to support the program. But starting in 2026, after those enhanced federal subsidies end, if they do, we expect funding to decline. The program cost will also decline somewhat, but it will still exceed the amount of funding we're bringing in. So we'll have to start drawing down on that reserve. So you see that red line is above the funding bars. The purple line of our reserve starts dropping as we pull down on that. Even so, we still anticipate we're in good shape through the end of 2028, which is the current 5-year waiver period that we have this approved with the federal government. Even with those drawdowns, we still anticipate that we would end 2028 with about $260 to $270 million in reserves in the program. So we're not concerned for the program's solvency at this point, but we are, going to be monitoring it closely. As we always do, but in particularly if ARPA wraps up at the end of 2025. Next slide. Here we see what our projections look like if those enhanced federal subsidies are extended past 2025. So you can see it's a more comfortable picture. That red line, the program cost, continues to be slightly below the program funding. And so we're able to cover our costs each year. Our reserve balance may grow incrementally year over year. We don't have that big drop in federal funding starting in 2026 that we saw in the previous scenario. So, in addition to all of the individual level impacts that losing those enhanced subsidies will have to individuals' premiums, we also hope that the subsidies get extended for the fiscal health of the reinsurance program. But again, in either scenario, we're comfortable with where we'll be through the end of 2028 financially. Next slide. So I think that wraps up reinsurance. I'll switch now to talking about the Young Adult Subsidies Program. So a little context, many of you, again, are familiar with why we did this program. It's because young adults 19 to 34 are the largest block of uninsured in the state when we're looking at who could be enrolled in a private plan through the exchange. So we want to target those individuals with everything in our arsenal to try to get them enrolled. First off, because it's just good for people to have coverage, have that financial protection and peace of mind and ability to use health insurance. And also because getting healthy people into the market brings down premiums for everybody. Next slide. So again, with the leadership from this committee, in 2022, we launched a pilot program to provide a state-funded premium subsidy to reduce those young adults' premiums. And in 2023, that 2-year pilot was extended an additional 2 years through the end of 2025. So the state subsidy pairs with the federal premium subsidies to reduce premium costs on a sliding scale. So the youngest and lowest income young adults pay the least. We're funded with up to $20 million a year from the state reinsurance fund. Last year, we gained legislative authority to roll over unspent funds from prior program years, which has helped us fund this year's program when we saw really tremendous growth in our young adult enrollment with the Medicaid unwinding. Next slide. So just a quick slide on what the program eligibility parameters are. The exchange has the authority to set those eligibility parameters within guardrails established in legislation. For 2022 and 2023, eligibility was for young adults 18 to 34 who are not eligible for Medicaid and are below 400% of the federal poverty level. In 2024 and 2025, because we had been underspending our 20 million kind of allocation, we expanded that eligibility slightly for adults up to age 37. And so this helps reduce the amount that they are on the hook for in their premium at each age, and it kind of phases out. So young adults 18 to 33 qualify for the largest amount of subsidy, and then from 34 through 37, it phases out. Next slide. So we implemented this in the midst of a lot of other changes going on in the health policy landscape. So in 2021, the year before the program started, we saw those enhanced federal subsidies begin. Then the program started in 2022, and we did see a jump in our young adult enrollment in that year, probably through a combination of those two elements. And then in 2023, the Medicaid unwinding started mid-year and continued into the middle of 2024. As those frozen individuals were sort of unlocked from Medicaid and moved into the individual market, we saw a tremendous growth in our young adult enrollment, as Michelle mentioned, increasing 26% year over year. Next slide. In terms of our annual spend for the program, we have been averaging a monthly subsidy for eligible individuals of around $36 to $38. It's been pretty consistent over the first 3 years of the program. And you can see that our spending it was significantly under our $20 million cap in 2022 and 2023. We attribute that largely to the Medicaid unwinding, keeping young folks in Medicaid, which, good reasons for that, but it meant our enrollment was lower than we had expected. Once the unwinding started, we saw that enrollment shoot up and our costs increased accordingly. Next slide. And again, a little bit more on the program impact. So that average monthly subsidy of $38 brings down
A lot of work that's gone into producing that, and very
out-of-pocket premiums by about 30%. And again, we saw that young adult increase 26% compared to a 17% enrollment increase for all ages. So the young adult enrollment significantly outpaced the all age enrollment. And since the year before the subsidy program started, we've seen an overall increase from 2021 to this year of 46% in young adults compared to a 30% increase when we look at all ages. So again, we're seeing young adult enrollment outpacing overall enrollment. From an equity perspective, we've seen this definitely being taken up by our Black and Hispanic young adults, with increases respectively of 46% and 50% in young adult enrollment in those communities. And we are deep in the weeds of working on a more detailed analysis of the program impact that's going to be submitted to the General Assembly later this year pursuant to legislation. So I think that's my last slide, and happy to take any questions.
Thank you. Thank you very much for your presentation. There are questions, and before we get there, I just want to say congratulations to you on the birth of your second child. HGO had a baby too, and his name is Jaden, and we all love Jaden, and he's the new HGO member, and you'll probably see him during session. So we're going to start first with my vice chair, followed by Delegate Taveras.
First of all, also I send my congratulations, Johanna. So happy. And glad to see you back. And I want to thank Michelle as well for her leadership of the exchange. This news is all very exciting to me. I really appreciate everything that you've done and the way you've strategically managed the different programs. And I also appreciate the way that you are looking at outcomes and the impact of the programs. I think you set a good model for us as legislators to make sure that we are, when we create policy, make sure that we're looking at what the policy actually does and whether or not it's working. So thank you for that. Given that, I'm wondering, and I think maybe this is part of the deeper dive that you're going to do into the young adult subsidies, but I'm wondering, in the same way that you sort of spoke to like the decrease in the more catastrophic incidences around diabetes because of increased enrollment in insurance and preventive care, if there's a way to look at that specifically to not diabetes necessarily, but the outcomes for the young adults, and do we see and maybe we don't have a baseline, I'm not sure, of these individuals, but if we do, can we compare those who didn't have insurance with those who do and their different health outcomes? Is that possible to do, number one? And number two, have you incorporated that into the deeper dive, I guess is the question.
That's a great question. And yes, the ultimate goal is really to impact health and people's care outcomes. I think that's something we can definitely talk to our partners at Hilltop, who we do that kind of claims and outcome analysis with, about doing. I would love to be able to do it if we can. It's a little tricky because we really saw the most significant impact from the program in 2024 as that unwinding was happening. So we haven't had a lot of experience where we've gotten the bulk of our enrollment under the program, because it was just a little bit weird to launch it during COVID with the Medicaid redetermination freeze. But I'll definitely talk to Hilltop about what we could do on that front.
I thank you for that. I appreciate it. I think number one, as you're absolutely correct. Number one is to keep people healthy. That's number one goal. But number two is when I speak to folks about insurance and how insurance works, I always say we need to have a risk pool where the risk actually goes down. And that's the justification we've used for the young adult program. I suspect you're going to make my case, and I want to be able to have that case made. So, anything we can do to make that case, I'd appreciate it. Thank you.
And Vice Chair Coulson, if I can just add to that, because just ironically enough today, there was a study that came out, and we can share this as well, that says the ACA provision linked to improve survival in young adult cancer patients.
Oh,
So that's not Maryland specific, but that's something we can share with the committee.
that'd be great. Thank you very much. Thank you so much for your work. I really appreciate it.
Thank you, Delegate Taveras.
Thank you, Madam
You're
Chair.
welcome.
This is a great presentation. I really enjoyed looking it over, and I love the increased statistics and equity that are there. The question that I had are which amongst the state reinsurance program enrollees that were not reimbursed, like what were the typical issues that were not reimbursable compared to those that were reimbursed, like what kind of things were, if it's just general upkeep, and if there is a possibility of even finding out of what's the percentage of those are, and if it's possible, I don't know if this is a HIPAA issue, what's the percentage of those that are receiving care due to drug addiction?
Those are great questions. So I'll just speak briefly. I think you're thinking about our slide 10, where we had the pie charts that were showing the portion of individuals and claims costs who have reimbursed or not reimbursed through the program. So for that perspective, we're not talking about any particular conditions. We're just saying for that 7% of individuals who had claims above $20,000 in the year, the $568 million of reinsurance funding covered half their claims, and the other half was covered by carriers. So that means the carriers had to cover any amounts of $20,000 and below or $250,000 and above, but it wasn't condition specific. It's just that there were enough claims kind of outside of what the reinsurance covered, the corridor of claims covered by the reinsurance program, that the carriers had to pick up that tab. That said, we do collect data from the carriers on what conditions are being covered for, or what conditions people who enter the reinsurance program have. So we collect particular data on substance use and behavioral health disorder, diabetes, asthma, pregnancy, and maternal health. We have kind of key areas that are in line with the state population health goals, where we ask carriers to submit additional detail. And then we collect overall what are the top 10 most costly conditions covered by the reinsurance program and the most common. And we track that year to year and have conversations with carriers about what they're doing to address those costs. So happy to share the report with that detail with the committee.
Thank you. I would love to see that.
Let me see if I see any other questions. Make sure I do not miss anyone. I do not see any other questions. So I want to say thank you so much for the presentation that you provided today. It was very useful. Having access to care, having insurance is very important. It's one of the goals of this committee. And we have collectively over the years worked to make sure that we pass such policies. And you are partners, right? We can pass all the bills in the world, but without having people like you implement them and making sure they work, it wouldn't happen. So on behalf of the committee and our team, our staff, I want to thank you for the work you do. We really appreciate it. And I want to thank our committee for showing up, for your questions, for your interest, for your time. and everyone out there watching. I hope you have a blessed day. And thank